Good afternoon all and welcome to e-NEETI, nurses' efforts to eliminate TB in India. I hope you all are doing well and ready for today's session. I am Shima John, nursing officer from our institute NITRD, and this is our eco meeting room and this 20th e-NEETI clinic today. As you all know that we conduct on every last Friday of every month or either third Friday of every month. So let's make the most use of this virtual space and create a dynamic and interactive environment. I could I could see many familiar faces here. I think most of them are have already joining since 20 months since its inception. Many are new also. Thank you for joining. It's great to have such an enthusiastic and knowledgeable group with us today. Thank you for joining. Today, we all will be discussing on side effects of the multi-drug resistant drugs. We will have questions at the end, so feel free to note down anything you would really like to ask. There are set ground rules that you have to follow. There are set ground rules, some guidelines which you have to follow to ensure smooth functioning and communication. First, I kindly request all of you to please mute your microphone so there is no distractive noises while on the session. And feel free to use your chat box and please don't interrupt and write down the points which you have to say or you can write in the chat box also. Doctor, moving on, I request Dr. Sanjay Gupta sir to please. Sir, are you there? Dr. Sanjay Gupta, sir, are you there?
Yes.
Sir, good morning. We would be honored if you could start this session with your valuable opening remarks, sir.
Well, as you said, this is the 20th e-NEETI session. So, congratulations on continuing with the this effort. And I think the today's topic is very good topic about the side effects of anti-TB drugs, especially those which are used for the drug-resistant TB. So, all the best, and please continue with this effort. Thank you.
Thank you, sir. Thank you so much. Now, let me introduce our dynamic team here with us. She's our NS ma'am, nursing superintendent of our institute from NITRD, and has been a master trainer for training of nurses in TB by ICN. She has been recognized by the ICN TB MDR TB project as a leading light in recognition of her outstanding contribution in the care of people affected by TB, conferred by ICN, Geneva, Switzerland. Welcome you, ma'am. Thank you. Next to her extreme right is our Dr. Prabpreet Sethi, and she is a senior specialist in our institute NITRD. She is dealing with MDR TB cases since 15 to 20 years. Ma'am is an expert for today, for the topic, for the today's agenda topic today. Ma'am, thank you for joining. Thank you for accepting to be an expert for this clinic. Now, this is she is our presenter, Miss Gayatri Anupam. She is also from our institute NITRD and she has been here since 11 years. She's been ICU and she's a presenter today. I request Gayatri to please continue with the presentation. Before that, I would say that I request all of you to please join through your email account now and not in a single account. Please join through your own accounts so that you could avail the facility of certificates. Otherwise, you won't get your certificates unless you join this class in your email account, through your email account. Thank you. Now, please, I request Mr. Gayatri to please continue the presentation.
Thank you so much, Shimaldi. Today, I am going to present a case. It is the side effects of ATT, and the case I have taken is one of our senior nursing officer in our institute, and I have taken the consent of her before presenting her case in this platform. We will talk about today about the tuberculosis types, diagnosis, treatment of drug-sensitive and drug-resistant TB, then case study of adverse effect of ATT, and then nursing management of the case with the help of nursing process. Now we will know, everyone know, but now just to remind, tuberculosis is an infectious disease caused by the Mycobacterium tuberculosis, characterized by pathologically by inflammatory infiltration, necrosis, abscesses, fibrosis, and calcification. It affects mainly respiratory system, but can affect any part of the body. These are the types of tuberculosis. According to the site, there are two type of tuberculosis, that is pulmonary and extrapulmonary. Pulmonary, that is 75% to 80% is all cases is of pulmonary TB, which affects mainly the respiratory system, means lung. Extrapulmonary tuberculosis can be in cervical, bone, pleural cavity, kidney, gastrointestinal tract, intestines, and any other plant-like skin also. So there are two types according to site of infection, pulmonary and extrapulmonary. According to resistance of drug, there is a 4 type of tuberculosis: monoresistant tuberculosis, polyresistant tuberculosis, multi-drug resistant tuberculosis, that is rifampicin and isoniazid resistant, and extensive drug resistant tuberculosis. Now we'll discuss about the medical management of tuberculosis, that is drug sensitive. The goals are to kill the bacteria, to stop the multiplication and prevent resistance. The duration is first, that is intensive phase, that is 6 months. It divided into 2 phases, that is first is intensive, in which we give rifampicin, isoniazid, pyrazinamide, and ethambutol for the 6 months. Then next continuation phase for the next 4 months is HRE, isoniazid, rifampicin, and ethambutol. We continue it to the next 4 months. Continue. Next. Now there is some medical management of drug-resistant tuberculosis. There is 3 groups of medicines. That is group A. It includes all 3 medicines. It is levofloxacin or moxifloxacin. Either levofloxacin or moxifloxacin can be used, bedaquiline and linezolid. In group B, we include clofazimine or cycloserine, clofazimine and cycloserine or telizorone. In group C, there is add to complete regimen when drugs from group A and B cannot be used. It's ethambutol or delamanid or pyrazinamide or imipenem, celestine or meropenem. Injection amikacin or streptomycin. Ethianamide or prothionamide. And next one, last one is PAS. It's a para-aminosalicylic acid. Now you can see the slide. This is the risk for potential adverse reaction. That is the main topic of today's case presentation. That is, you can see the QT prolongation. It's a bedaquiline. Drug is bedaquiline or fluoroquinolone or clofazimine. There is a QT prolongation that may lead to arrhythmia. And any drug, the rash, allergy, and reaction can be present with any drug. And ethionamide, pyrazinamide, ethambutol, bedaquiline, clofazimine, and isoniazid can lead to gastrointestinal system symptoms. And pyrazinamide, isoniazid, ethionamide, and bedaquiline can be the adverse effect can be hepatitis. Giddiness can be due to ethionamide or pyrazinamide. Hypothyroidism can be due to ethionamide. And now you can see peripheral neuropathy. It's very important. It can be due to linezolid or isoniazid, and headache can be due to bedaquiline. Depression can be due to isoniazid, ethionamide, and cycloserine. There is some psychotic symptoms also, which can be present due to isoniazid. Suicidal ideation, which can be due to isoniazid or and cycloserine. Seizures can be due to isoniazid, and tendon rupture can be due to fluoroquinolone. Vestibular toxicity, it can be present in many patients. We can see it can be due to isoniazid and ethionamide. Optic neuritis, it can be due to linezolid, ethionamide, clofazimine, and isoniazid. Metallic taste, it can taste the change of mouth. It can be due to ethionamide and fluoroquinolone. And now you can see alopecia, that is loss of hair. It can be due to isoniazid or ethionamide. And superficial lung fungal infection anthrax, it can be due to fluoroquinolone. And hyperglycemia, it can be due to ethionamide. Next slide. Now we can see this for potential adverse reactions of the ATT, multi-drug resistant TB. It's a levofloxacin, and the possible drug adverse reaction is QTC prolongation. That may lead to arrhythmia, and arrhythmia can lead to cardiac arrest. So it's a very important thing to know about this. As a nurse, we are very close to patients, so we should know about the side effects of these drugs. So ECG, and what is our nursing activity before administering these drugs? We should always do the ECG before administration, so that we can know what is the QTC prolongation, what is the if any arrhythmia or any type of abnormality is present in ECG. Bedaquiline, it's a 400 mg once a day. First we give for first 14 days, then we give 200 mg for next alternate day. It can be lead to QTC prolongation. And linezolid, it's a 600 mg once in a day. It can lead to optic neuritis, anemia, and in this case, we can look the patient's activity. We can ask that if there is any tingling and numbness is present in the patient or not, so that we can early identify and early report to about the any adverse effect. Clofazimine, it's a 100 mg once in a day. It can lead to discoloration of the skin. And you can find it in many patients. I have seen the many patients who is taking clofazimine has this side effect. It's a nursing activities. Before starting this medicine, we can counsel the medicine that this is necessary to add this medicine. So before starting this medicine, we should always counsel the patient about this adverse effect. And cycloserine, it can change, it can lead to psychotic and suicidal ideas. And in this in nursing activity, we should always explain these side effects to one of the closest relatives of the patient, so that they can keep eye on the patient's activity and reports if there is any behavioral changes or any other symptoms that can lead to depression, that can show the depression in the patient. Next. Now I am going to present our case, that is a drug adverse effect of ATT, and the patient taken is one of our most senior nursing officer, and consent of her has already been taken from her to present her case on this platform. This is demographic identification data of the patient. The name is Mrs. S. Age is 56 years, female, married, Christian. She belongs to Christian community. Education is general nursing and midwife. Occupation, she is working as a senior nursing officer in this institute from last 25 years. She is very senior staff. She lives in Mehrauli, and she is diagnosed as the extrapulmonary tuberculosis, multi-drug resistant extrapulmonary tuberculosis. She admitted in our institute on 12th of October. The symptom which was started was, her chief complaints was, it was started with back pain, restlessness, anxiety, depressing thoughts, loss of appetite, insomnia, weakness, and nausea. Next. The post-medical surgical history was taken. It's very important. Patient is a known case of diabetes mellitus type 2, and she is on medication. A history of taking ATT. She has already taken ATT in 2013 for the neck lymph node tuberculosis, and she has completed the 9-month course. Again, she has given a history of cholecystectomy in year 2015. A history of category 1 ATT again in 2019 due to Cox abdomen. Again, she has completed the 9-month course. No other significant past medical history was present. The two main history, that is, she has taken 2-time ATT in last 10 to 15 years back, one in 2013 and second is 2019, and at both times she has completed the course. Next. Socioeconomic status is she belongs to a very good family. There is 2 earning member present in her family. Income is 15 to 20 lakh per annum. Socioeconomic class, she belongs to upper middle class. Housing conditions, she lives in well ventilated house and she is taking RO water, purified water. Her family history was taken. She lives in a nuclear family of 4 persons with her husband and 2 children. Husband and both the children are quite healthy. And one important history is she has given that her sister had a history of patent tuberculosis drug in 20 years back. There is no other significant medical history is present. You can see the family tree, the patient, husband, son and daughter. The patient who is showing red is a diseased person. Husband, son and daughter they are the healthy person. Lifestyle and dietary habits. She is a non-vegetarian. She takes non-vegetarian diet once in a week. And nowadays, she has a complaint of decreased appetite due to hospitalization or maybe due to medication. There is not known any food or drug allergy. I have taken history of her sleeping pattern. She had sound sleep of approx 8 to 9 hours in past, but now has disturbed sleep due to some anxiety or due to some medication. Bowel and bladder habits is regular. Next. Her physical examination was done. On general examination, general condition is poor at the time of admission. General body build is endomorphic. Vital signs was taken. It was temperature was normal. Pulse so some tachycardia, respiratory and tachypnea. Blood pressure was normal. SpO2 was normal on room air. And the history of present illness was the patient was totally asymptomatic 1 year back when she developed pain in her lower back in sacrum area. She has consulted orthopedic department in private hospital in October 2023 and they prescribed some medicine and physiotherapy. The pain had somehow subsided with the help of physiotherapy and some painkiller medicine. But it again started in December 2023 and this time it was radiating to her right leg also. Some amount of very mild amount of numbness and tingling was also present, and at this time she has noticed significant weight loss. She had consulted spine specialist. MRI of spine was done, and in reports there was a central disc herniation from L3 to L5 and diffuse disc bulges with central annular tear. And transforaminal injection it was given in her back in December 2023 in private hospital. Again, the lower back pain again increased in January 2024. With the help of injection, the pain was subsided only for 15 days. And again, it was started in January 2024. And this time she noticed tingling and numbness in both the legs. She was diagnosed as a case of, she consulted spine specialist and at this time she was diagnosed as a case of base compression of fracture L2 to L3 reticulopathy. And according they have said that there is some compression of nerves in her lower back area. That's why they have planned screw fixation and laminectomy. That was the surgery was done in January 2024 in private hospital. And lower back pain was somehow improved after the surgery. From January to April, she was on medical leave. And again in April 2024, when she joined institute and somehow her activity was increased, she noticed some abscess over that surgical area. Where the surgery was done, was some abscess. There was a small abscess. She again consulted to the hospital and that wound was drained and first was sent for the examination. Culture examination and rest other CBNAT and LLP examination. In CBNAT report, its report was mycobacterium tuberculosis was detected in her pus, in wound pus, and that was epamecin resistant, isoniazide resistant, ethambutol resistant, and parazenamide sensitive. In the pus report, the treatment immediately treatment was started for the multidrug resistant extrapulmonary tuberculosis, and that is started with tablet Viraquilin 400 mg once in a day for 14 days, and then 200 mg alternate day. Tablet Linezolid 600 mg twice in a day. Tablet moxifloxacin 1000 mg once in a day. Tablet cycloserine 750 mg once in a day, and tablet pyridoxine 100 mg once in a day. With in addition with clofazimine 100 mg once in a day. In May 2024, she was noticed she was taking medicine, started medicine in April 2024. Then in May 2000, after completion of 1 month, she noticed burning sensation in both the leg again, and she was unable to walk properly. Then drug susceptibility test was done, and report was it's moxifloxacin and levofloxacin resistant. In May 2024, tablet linezolid stopped and tablet delamanid were added due to tingling and numbness in the lower limbs. In May to October 2024, May to October, for 3 months, the same treatment were continued. In October 2024, these medicine were started. These were added in that medicine. It's parazinamide, 750 mg according to her weight, and tablet ethanamide 1000 mg once in a day. Again, only after 2 days of taking pyramid, these are very important thing. You can write it down. Only after 2 days of taking parazinamide, she developed severe anxiety and restlessness, weakness, and complete loss of appetite, including with insomnia also. Parazinamide and ethanamide discontinued for 3 days, and after it started after 3 days. Again, when it restarted after 3 days, she has complained of drowsiness, including ghabrahat, restless was present, and in this time drowsiness was also present. And then parazinamide and ethanamide were stopped. They stopped completely, and para-aminosalicylic acid was added on 11th October 2024. But after taking first dose of PAS, she had complaints of loss of alertness, ghabrahat, semi-consciousness, nausea, and vomiting, and she was not even able to talk properly or walk properly. At this time, she was admitted in NITRD on 12th October. The blood on the examination, her alertness was poor. Blood investigation was normal. Chest X-ray was normal, and symptomatic treatment were given with the help of antiemetic, antacid. IV fluid administration was done, and para-aminosalicylic acid was stopped. After symptoms improved, the modified regimen was started with the tablet bedaquiline continued, or alternate day tablet clofazimine also continued, cycloserine 750 mg continued with, and delamanid 100 mg it's twice a day it's continued. And she was discharged in stable condition on 15th of October 2024. After 2 days, she had developed 2 days of taking these regimens. She has again developed severe anxiety and crying episodes. She had she was advised to take psychiatric opinion, and she had consulted a psychiatrist, and was diagnosed with a case of severe depression and anxiety. Antipsychotic medicine was started, and counseling was advised. 2 sessions of counseling was done already. On 11th of November, she attempted suicide by ingesting approx 10 tablets of alprazolam, and was brought to the hospital by her family member. The history was given by her daughter. After stabilization of her condition, she was discharged on 12th of November from the private hospital. And at the advice given on the discharge that stop with tablet cycloserine immediately, that it can lead to psychotic symptoms, and close observation of the patient, not to be left alone as there is a risk of self-harm. MDR medicine to be continued with bedaquiline, delamanid, and clofazimine. Cycloserine were stopped. Antipsychotic drugs to be continued, and counseling to be continued. Now we'll move on to nursing management. The nursing diagnosis was the risk for infection related to poor nutritional state, as she was taking poor intake. She has poor oral intake was poor, so WBC was monitored to know the if any case any risk of an infection, and sputum sample was sent for AFB and CBNAT and other examination to know the if the disease has spread to any other organ or to the lungs. Examined for the sign of any symptom of infection, so that any kind of infection can early be identified and detected. Second, the nursing diagnosis again was the impaired nutrition related to loss of appetite. Understanding of individual nutritional needs to nursing assessment was assess the dietary habits, advise small and frequent meals. He has been advised to take small amount of meal in and frequent time to digest properly, and the monitor patients weight periodically, advise high protein diet. Again, anxiety, the nursing diagnosis is anxiety related to fear of outcome. Assess the family understanding about the disease. The family member has been counseled about the side effects and to build the strong social support and safe environment. Displayed a confident, calm manner and understanding attitude. Presence of trusted person may be helpful during the period of anxiety. So her daughter is a very strong social support for her. She present 24/7 with her, and encourage patient to express her feeling and ask questions to facilitate open communication. The emotional support was provided by her family member not to live alone. Her daughter has become a strong source of support. She has taken a break for her well-paid leave, and she is taking care of her mother 24/7, and she is taking care of her diet and medicine and everything. Workplace support was provided with the help of our nursing superintendent, assistant nursing superintendent, deputy nursing superintendent, and her colleagues and the junior staffs. The patient, we have tried to engage her in some work so that her mind can be diverted and negative thought chain can be broken. So every day the peer group meets her and counsel her about and try to give the positive thinking, positive attitude. Next. Advice to maintain healthy lifestyle. Advice to do some activity as per her interest. She has been advised to do some activity according as per her interest to break the chain of negative thoughts. The key point is managing a patient who has attempted suicide and has a chronic disease requires a comprehensive and compassionate approach. Here are some key aspects of nursing management for such patients. Risk assessment and safety measures. As we nurses are mostly we are in the contact of the patient, so we can identify these symptoms early. Conduct through the risk assessment to evaluate the patient's current mental state, suicidal ideation, and potential triggers. Ensure a safe environment by removing any potential means of self-harm and closely monitoring the patients. We try to remove any objects that can harm to the patient. We try to keep away from the patient. Therapeutic relationship, we try to maintain a strong therapeutic relationship with the patient to maintain open communication so that they can be comfortable and can communicate anything they feel to us. Listen actively and empathetically to the patient's concern and the feeling, so that he can share his feeling and concern towards his health, he does his own health with his healthcare facilitator. Emotional support and coping mechanism. Offer emotional support to help the patient deal with the feelings of hopelessness and despair. Encourage positive coping mechanisms such as engaging in hobbies, physical activities, and social interactions. As I have told earlier, that we are doing this thing already in our hospital. We are trying to provide the positive environment to her. She is trying to engage in some positive work, constructive work, so that the motive is to maintain the positive environment and to break the negative thinking chain. A collaborative care is coordinate with other healthcare professionals to manage the patient chronic disease and mental health simultaneously. Involve family members in the care plan to provide additional support and monitoring. And in our case, her family members are very cooperative. Husband and both children are taking very good care of the patient. So by addressing both the mental health and chronic disease aspects, nurses can help improve the overall well-being and quality of life for for our patients. These are the adverse drug reactions we have discussed already, so we are not going to discuss again. I will discuss about the next slide, please, which was present in our patient. Next. Adverse reaction that was present in the patient was bedaquiline related QTC prolongation that may lead to arrhythmia. It was not present. Clofazimine skin discoloration is present, strongly present in fact. And cycloserine, depression, anxiety, suicidal thought, it is present in the patient. Ethanamide, gastritis, hyperglycemia is present in the patient, and she is on medication. Giddiness is also present. Lanazolid, peripheral neuropathy, it was also present, and that's why this medicine has been stopped. Now there is a message, TB को रोकें, उनके मरीजों को नहीं, and thank you all for listening with patience. Thank you.
Thank you, Gayatri. It was a standout presentation. I think all the learners must now have a complete knowledge, information, awareness about the side effects of ATT drugs. Now, ma'am, Dr. Sethi ma'am, will you please, I would be greatly appreciate if you could say something on enhance some more about this on the topic. Additional depth or explanation of this she might have left in the slide.
Yeah, she has presented really well. Thank you so much. But what I want to just emphasize on this case is that one, we should understand tuberculosis has been and still continues to be a taboo disease. So once, as a nursing staff or as a medical professional, one thing foremost is to remove this taboo. We should be open to all the patients as well as the relatives. Explain to them that though it is infectious, but it is a treatable disease. And that enforcement that it is a treatable disease really helps the patient and the relatives to remove that taboo. Second is to understand what is MDR-TB or the drug-resistant TB. Drug-resistant TB, tuberculosis, you understand, is a lengthy treatment, plus the number of drugs required are more. These drugs, though effective, are having more side effects. So taking this medication for such a long time, practically for 2 years, 18 to 24 months, is not a joke. So you have to be available to the patient and the relatives in one-to-one basis, where the communication between the patient and the medical fraternity should be open. They should have the faith that with little complaints also we should be approachable to them. They should not fear that what will we think, or whether, or we just shun off or theek ho jayega. No, listen to them, even a smallest, because these small, as in this case we've seen, the smaller complaint, had it been kind of, we were receptive to those, it would have not led to this stage where she had attempted a suicide. So we have to be, first and foremost, we have to be aware of the side effects. Once we are aware, then only we will be able to be receptive to what the patient is saying and understand, yes, okay, this could be the possible reason why this, and take appropriate action, either of stopping or whatever the appropriate action is. So you have to know all the side effects, you should be aware of these side effects and be empathetic to the patient, listen to what they have to say. As a medical professional, what we have to learn from this case is that we have to catch hold of all the side effects at the earliest. Because as you must have understood and heard since childhood that prevention is better than cure. Now we are giving her treatment for antipsychotics or anything, but had it been, if we catch hold of these symptoms prior, it is always to prevent. Is any day is better to land up in this situation. Okay, so be aware of all the side effects, which sister has told beautifully and explained, and the kind of exposure you've been seeing these patients for so long. I don't think you could have any problem. Yes, the doctors are available freely. I don't think we have that kind of a very good communication in our institute at least. So be approachable, talk to the patient. You understand something, talk to the doctor, so that these things can be upheld right in the beginning. Due action can be taken, and we do not see our patients landing here in such a poor condition. So that is what you have to learn. Prevention is better than cure. Open your eyes, be empathetic, be available for the patients. So this is just for the general, and I'm open to any questions if you have particularly about any drug or any according to this case.
Thank you, ma'am. We have enlisted your what she had overlooked the aspects. Thank you for bringing it in mind of all the learners. Thank you, ma'am. Now we are now moving to the open house discussion. Anybody feel free to ask any questions on this topic, regarding this topic, on this topic. If you could not say, please, you can write in the chat box. Any queries? Feel free to ask questions. It's an important topic. MDR, TB, side effects is an important topic. You could ask anything, any doubt, you could clear it today. It's a great time to get clarity on this subject.
It would have to start a ATT drug in the trail even if that person doesn't have any symptoms, or sputum and the CB net has become negative.
Is it okay to, there is a question in the chat box, is it okay to start a ATT drug in trail
in trial
as a trial?
Yeah.
Even if that person doesn't have any symptoms and also their sputum and CB nat has come negative?
See, I think if I can take this question, every trial has a specific intake, exclusion and inclusion criteria. For tuberculosis, I don't think you have any inclusion. Any trial has an inclusion criteria where you do not have a demonstrated or microbiologically confirmed TB. So I don't. If you could specify exactly what you want to know, which trial you are talking about, but more or less, if it is a tuberculosis trial, they usually have microbiologically confirmed TB cases, because ultimately if they're testing the drugs, so they need to have confirmed TB. So I'm not very sure what trial you are talking about. If the patient is negative, does not have a microbiologically active TB, they wouldn't put her in the trial.
I think we got the clarification. Anyone else? See, this is the best platform for learning such queries. Anything you are curious about, you can ask here.
So if I could add one thing, you should be very aware of there are certain things called as serious side effects and which are mild side effects. So you should be, as a clinician or as a medical fraternity person, you should be able to differentiate whether this is just a mild side effect or it is a serious side effect. See, even a vomiting, though it seems is a very mild, every drug has some kind of a nausea or some kind of a vomiting, but then that can land up into a serious side effect. So you should be aware of that. See, once a few vomiting which does not cause great means the hydration is maintained, the tongue is moist. That is how you assess the hydration part, right? The BP is maintained, pulse is okay, but tongue is moist. So you know the hydration is maintained. Then probably vomiting is just a mild side effect. But as the one who attends to a patient at the first point of contact is what? Nursing staff. So at that stage, you should be aware what are the signs and symptoms. Even with mild side effects, you have to see and assess whether it has turned up into a serious side effect. If you see a patient who is taking, and any drug for that matter, has landed up with vomiting, and you see that the BP is, she has hypotension, the pulse is of low volume, the hydration is not maintained, then that turns into a serious side effect. These side effects are to be reported under TB program. Also, there is something called pharmacovigilance and adverse side effects reporting. So these two things have been taking place, and when you see these patients, and you have to report these either serious side effects or even any drug causing So both the aspects, pharmacovigilance, and these have to be taken care of, and these things have to be reported. While you are working in the hospital, you have a patient in the ward, you know has serious side effects, you need to report them. So there is a proper pro forma center. You will have to get in touch with your DRTB form, and we'll have to. So if not much, yes, at least the judgment that it is a serious side effect should be from your side, and you can obviously then tell your doctors, which would get in contact with the DRTB people and then fill those forms. So these are very, very helpful in later on in policy making decisions, because when you know that certain drug is causing too much of problem in most of the patients, then you know that those drugs will come in the priority list and lower down. So these things are very important, though it seems very futile. अरे क्या करना है, vomiting ही तो है. No, but if these side effects are reported and at the CTD level when they are assessed, many actions can be taken. So you as a first point of contact should understand your contribution in this program is very essential and very important. So be aware, just go through this, just a simple table which is shown where the drugs and the side effects, even if you paste them in your ward, just a simple one page printout, you know, okay, this patient is taking this drug and this is what she's having. Okay, this could be one thing. So this is how when it comes in your practice, you will learn and you will be more confident in dealing with these patients. So serious side effects and any particular drug with pharmacovigilance, these two things have to be reported. So you should be aware of those two things.
Any questions? See, if you have a question but feeling unsure to ask, go ahead and ask. By asking, you will be helping others in the group too. No more questions? Yes, Sushila, sister, want to ask anything?
You ask anything? खत्म कर दिया लग रहा है
पहले ये पूछा था ना कौन कौन इंटरेस्टेड है.
हाँ
से रेजिस्टेंट था तो दोबारा क्यों शिफ्ट करी फाइल में.
So no more queries?
सबसे फर्स्ट में रेजिस्टेंट था. ये सेंसिटिव
If you are feeling unsure, you can put in the chat box too. Okay, no more questions. So we can stop here. On behalf of entire team here, thank you for attending the class. We hope you had a nice time. You got information. Many of you, I could see the names here. It only so voice. There is distracting noises, please. If you are not asking anything, mute your speakers, microphones. So thank you all for attending this session. We'll be all meeting next month, last Friday or either the third Friday with a new topic. With new ideas, new insights. Thank you. Have a wonderful day. Okay, please let you, all of you, please give your feedback. You'll receive a link. Give your feedback. We are keeping this session open for 2 minutes more so that you could provide your feedback.
Yes, sir.
See, your feedback only make us improve. Okay, thank you all. Have a wonderful day. Thank you.
Ideally, excludable.
కారం